Hello everyone, welcome to Logic Medico. Today's interesting topic is midgut and its derivatives. Also a note on rotation of the midgut and its congenital anomalies. So let's understand what is midgut. It is that portion of the yolk sac which is there between the two lateral folds of the embryo. So initially the midgut, it forms a ventral loop like this and it projects beyond the umbilicus because the abdomen is occupied by the developing liver, that is a hepatic bud, and the mesonephros or the kidney. So this fills up the entire abdomen of a embryo. Therefore, the midgut loop with ventral convexity projects beyond the umbilicus to develop within an area outside the abdomen. This is called as midgut loop. As we can see, there is one dorsal aorta on the posterior aspect, and this artery is the artery for the midgut, which subsequently becomes the superior mesenteric artery. Now this midgut loop has got two aspects: the pre-arterial segments, which is the upper portion, the post-arterial segment, which is the lower portion. So midgut loop projecting beyond the umbilicus, deriving blood supply from the dorsal aorta, has got two segments. What is it? Pre-arterial, post-arterial. Initially, this midgut loop is present in the sagittal plane. That's in the midline plane, vertical plane in the midline. Subsequently, it will rotate. So before it rotates, it will develop one bud like this. That bud is coming from the post-arterial segment, and that bud is called fecal bud. The fecal bud, as the name suggests, will definitely give rise to the cecum, and the distal portion of the bud becomes narrow to give rise to the appendix. So the derivative of fecal bud is definitely cecum, and also distal portion becomes narrow to form the appendix. So the fecal bud forms in the post-arterial segment of the midgut loop. From this midgut loop, there is a diverticulum. You can see that there is a diverticulum going forward from the convexity. That is called Vitalo-intestinal diverticulum or Vitalo-intestinal duct. It is important for the formation of the midgut loop within the umbilical coelom. Failure of regression of this vitalo-intestinal duct results in umbilical fistula, that is fecal fistula. The feces from the intestines will end up coming out of the umbilicus. Vitalo-intestinal duct persisting near the umbilicus results in a rasberry tumor, that is the mucosal surface at the umbilicus resembles a berry called as rasberry. Proximal portion of the vitalo-intestinal duct, if it persists, it results in meckel's diverticulum. Meckel's diverticulum is a diverticulum present in the small intestine, which represents the proximal portion of the vitalo-intestinal duct, and that is occurring in 2% of population. Rule of 2 is there. 2% of population. Two ectopic tissues are there: gastric tissue and pancreatic tissue. It is 2 feet proximal to this ileocecal junction, and it is 2 centimeters in diameter. So this is the rule of 2. Then if the vitalo-intestinal duct persists in the center, it results in enterocele, that is one cyst which is present deep to the umbilicus, connecting the umbilicus to the small intestine. So these are the anomalies with respect to vitalo-intestinal duct. Coming back to the pre-arterial and post-arterial segment, the pre-arterial segment is cephalic or superior, and the post-arterial segment is inferior or caudal. In the post-arterial segment, we already saw there is a fecal bud which later gives rise to the cecum, and distal portion becomes narrow to form the appendix. Initially this is present, the midgut loop is present in the sagittal plane. So subsequently what happens, because of the developing liver bud, so there is a liver bud which is growing over here, the cranial aspect. So because of the development of the liver bud, what happens? Just one second, sorry. The pre-arterial segment, it presses on the midgut loop. So the pre-arterial segment comes to lie on the right side of the body, whereas the post-arterial segment comes to lie on the left side of the body. So this is the pre-arterial segment, which is now on the right side of the body, and the post-arterial segment, which is on the left side of the body. There is a 90-degree rotation of the midgut loop. So still the artery we can see in the axial of the midgut loop. Now the midgut loop is oriented in the transverse of the horizontal plane. Subsequently, what happens? The pre-arterial and post-arterial segment develops. The pre-arterial segment develops into the small intestine, that is the duodenum, jejunum and ileum. The post-arterial segment gives rise to the terminal ileum, the cecum and the appendix from the cecal bud, and the associated colon. We can see that over here. Subsequently, after the formation of this, some part of the small intestine, some part of the midgut loop has to enter back the abdomen, because the developing liver and the kidney has regressed in size at this point. Therefore, the pre-arterial segment which was there, the right segment, which is now called the right segment, that will enter the abdomen first. So this small intestine is going back, you can see that, into the abdomen. So it becomes a C-shaped portion, that's called the duodenum. Subsequent portion which is tortuous, and that is jejunum, and terminal portion is called the ileum. We can see the cecum and the associated colon is present horizontally. Initially the cecum and the associated colon is present horizontally. So first the small intestine enters the abdomen, then the cecum and the associated colon enters the abdomen. When the cecum and the associated colon enters the abdomen, there is no enough amount of space in the abdomen. So the cecum tends to go into the right iliac fossa. Initially there is no space, it's filled by small intestine. Tries to go in the right hypochondrium, liver is there, left hypochondrium, spleen and kidney is there. So it finally gets a space only in the left iliac fossa. Subsequently, it undergoes rotation from the left iliac fossa towards the subhepatic region, that is approximately 180 degree of rotation. From the left iliac fossa across the umbilicus towards the right hypochondrium. Once it reaches the right hypochondrium, the cecum and the associated colon is now oriented horizontally. You can clearly see the superior mesenteric artery coming in front of the duodenum, but it is deep to the cecum and the associated colon. Subsequently, what happens? The cecum and the associated colon grows downwards. When it grows downwards, it gives rise to a new portion of the colon, and that is called the ascending colon. So this new colon which has grown is the ascending colon, while the remaining portion of the colon which remain horizontal, that will give rise to a transverse colon. So the cecum and the associated colon give rise to the following things: the terminal ileum, the terminal most part of the ileum. The cecal bud give rise to the cecum, and the distal portion of the cecal bud narrows to form the appendix. The cecal bud grows downwards from the right hypochondrium towards the right lumbar and finally to the right iliac fossa. When it descends downward like this, it gives rise to a new segment, and that is called as ascending colon. The initial portion which remains horizontal gives rise to the transverse colon. We can see the superior mesenteric artery supplying the duodenum, the jejunum, ileum by duodenal, jejunal and ileal arteries, and continuing as the ileocolic artery, that is splitting into anterior cecal, posterior cecal and appendicular artery. Subsequently, it gives right colic artery which gives ascending and descending branch, and middle colic artery which gives right and left branch. So supplying the midgut loop. In summary, the pre-arterial segment of the midgut gives rise to the small intestine, which includes the duodenum, the jejunum and the ileum. Whereas the post-arterial segment of the midgut loop gives rise to the terminal ileum, the cecal bud gives rise to the cecum and appendix. The new segment which has grown downwards because of the downward movement of the cecal bud, the new portion of the colon which has grown is called the ascending colon, which remains retroperitoneal, whereas the pre-existing cecum and associated colon which remains horizontal gives rise to the transverse colon. Only the right 2/3 of the transverse colon is given rise by this midgut loop, that is a post-arterial segment of midgut loop, cecum and associated colon. The superior retention band will give rise to what is the superior retention band? Initially when the midgut loop is like this, the mesentery is there, it's called the dorsal mesentery. It will have bands, the upper and the lower end of this will have a band. It's called the superior and inferior retention band. The superior retention band will give rise to the suspensory ligament of duodenum or the ligament of Treats, whereas the inferior retention band gives rise to the phrenico-colic ligament. The fate of the artery to the midgut, it becomes superior mesenteric artery supplying the small intestine and majority of the large intestine up to the right 2/3 of transverse colon. Now coming to the anomalies with the midgut rotation. The failure of rotation of the midgut is called as non-rotation. So small intestine remains on right side, large intestine remains on left side. It's called as non-rotation. There's something called malrotation. Instead of this small intestine entering the abdomen first, if at all large intestine enters first, then the large intestine will be behind this superior mesenteric artery, then comes the small intestine. Small intestine will more forward in this case. This is called as malrotation, M-A-L, malrotation. Then there is something called partial rotation in which the cecal bud enters, but it remains like this on the left iliac fossa. That is failure. Initial 90-degree rotation outside in the umbilical coelom will take place. Subsequently, the physiological hernia, which has to reduce in 10th week of intrauterine life, from 5th week to 10th week, the intrauterine life, physiological umbilical hernia will be there. The small intestine and large intestine will grow in this herniated sac. But if at all the failure of regression of that will result in omphalocele, that is covered by amniotic membrane. Gastroschisis is an abnormality in the anterior abdominal wall where there is failure of formation of the anterior abdominal wall. Entire intestines are exposed to the exterior without a covering of amniotic membrane. That is called gastroschisis. Then cecum, initially it rotates, 90-degree rotation is there in the physiological umbilical hernia, but subsequent rotation is not there. So the cecum remains in the left iliac fossa. In this case, if at all the person gets appendicitis, the pain will be first noted in the left iliac fossa. Of course, first in the umbilicus, later radiate into the shifting towards initially radiation pain in the umbilicus, subsequently shifting of the pain towards left iliac fossa because cecum and appendix is there in left iliac fossa. Then if at all the instead of 180-degree rotation, if 90-degree rotation takes place, then the cecum and appendix will come and located in the umbilical region. If all the 180-degree rotation is proper, but the cecal bud doesn't descend downwards, then the cecal and appendix will be found in the like this subhepatic region, subhepatic cecum or subhepatic appendix we call it as. If at all it grows till here and subsequently grows downwards, but midway it stops, so the cecum and appendix will be there in the kidney region, that is the right lumbar region. Ultimately it has to descend in the right iliac fossa. If it doesn't descend exactly into the right iliac fossa or it over descends, then there will be pelvic cecum and appendix. So these are the possible congenital anomalies of rotation of the midgut loop. In addition, I already told you about the Meckel's diverticulum, proximal portion of the vitalointestinal duct, persistent, rule of 2. 2% of population, 2 ectopic tissue, gastric and pancreatic tissue, 2 feet proximal to the ileocecal junction, and it will be somewhere here, and 2 centimeters in diameter. And I also told you about rasberry tumor, distal portion of the vitalointestinal duct if it persists, and this is rasberry tumor. Then I told you about enterocele, the middle portion of the vitalointestinal duct if it persists, it's called enterocele. It appears like a sebaceous cyst deep to the umbilicus, okay, connected by a fibrous cord on either side towards the umbilicus and towards the intestine. Last but not the least, the patent vitalointestinal duct, the entire intestines are connected to the umbilicus, so it results in umbilical fistula. It's also called fecal fistula because fecal matters come out of the umbilicus. So this is in detail about the midgut development, rotation and anomalies. Thank you for watching and learning from Logic Medico.